Welcome everybody to this first of 3 past test video presentations designed for the MRCP Part 1 examination. The first session deals with anemias and cytopenias. My name is Keith Patterson. I'm a consultant haematologist. I have both DGH and teaching hospital experience, and I've been teaching on behalf of past test for a number of years. So, if you'll now look at and consider the first question. A 51-year-old man is rejected as a blood donor because he is found to be anemic at his screening blood test. He has a hemoglobin of 9.2 with a microcytic hypochromic blood picture with a low MCV and a low MCH, but with a normal white cell count and a normal platelet count. His routine biochemistry tests, including electrolytes and liver function, are normal. His serum iron is elevated, his TIBC is normal, and his serum ferritin is elevated. He has a normal ESR of 10 millimeters per hour, and his hemoglobinopathy screen and hemoglobin A2 level are in the normal range. The questions relating to this stem: what is the most likely diagnosis? And I'll let you read and consider those. So, hemochromatosis is the first potential option. This is, of course, incorrect, as hemochromatosis is not associated with anemia. That is, unless there has been some rather over-enthusiastic venesection therapy which has resulted in iron deficiency. The correct response is, in fact, item D, sideroblastic anemia, but I'm going to go through the other causes of microcytic hypochromic anemia. The commonest cause worldwide of a microcytic anemia is iron deficiency. However, in this particular case, we can see from measurement of the serum iron, which is high, TIBC, which is normal, ferritin, which is high, he does not appear to be iron deficient. The anemia of chronic disease is usually normocytic and normochromic. However, this is a healthy, apparently healthy blood donor who was found to be anemic at a screening test, so he doesn't seem to have a chronic disease. And also we know that his ESR is within the normal range, so there's no real evidence of inflammation. So the anemia of chronic disease does not seem to be a likely option. The most likely diagnosis in this case is item D, sideroblastic anemia, which may be associated with a low, normal or high mean cell volume. Before we consider sideroblastic anemia, let us dismiss thalassemia trait. Beta thalassemia trait is associated with a microcytic hypochromic anemia, usually with a hemoglobin over 9, common in patients of Mediterranean or Middle Eastern origin. However, we've seen that the hemoglobinopathy screen is normal and the hemoglobin A2 level is also normal. Patients with beta thalassemia trait are unable to make enough beta chains for adult hemoglobin A. Consequently, they compensate by making more hemoglobin A2, and an elevated A2 level is a useful marker for beta thalassemia trait. However, that is not the diagnosis here. So we have seen some of the causes of a microcytic anemia, of which iron deficiency, thalassemia trait, both beta thalassemia trait and alpha thalassemia trait, the anemia of chronic disease, and sideroblastic anemia are all possible causes. In this case, we're dealing with sideroblastic anemia, and I'm going to talk briefly about sideroblastic anemia. In sideroblastic anemia, there is an inability to incorporate iron in the hemoglobin molecule. There is a biochemical block within the normoblast in the bone marrow. Consequently, iron accumulates in the factory, that's the mitochondria, within the normoblasts, and that mitochondrion becomes poisoned. That forms an iron granules, and when you get enough iron granules, they form a ring around the nucleus of the cell. That is a ring sideroblast, which is the pathognomonic feature of sideroblastic anemia. Sideroblastic anemia may be congenital. There is a very rare sex-linked pyridoxine-responsive form, or more commonly it may be acquired, and the most common acquired sideroblastic anemia is one of the myelodysplastic states, that is refractory anemia with ring sideroblasts, RARS. Causes of secondary sideroblastic change include collagen diseases, malignancy somewhere in the body, and drugs, particularly the anti-tuberculous drugs, and occasionally heavy metal poisoning. We'll now consider the next question. This is a 50-year-old man with a history of alcohol excess. He presents complaining of arthralgia, painful joints. On examination, he is noticed to have pigmented skin and an enlarged liver. He has some blood investigations, including a normal blood count, normal urea and electrolytes, and mildly deranged liver function tests with elevation of both enzymes and bilirubin. His serum iron is elevated, his TIBC is normal, and his ferritin is elevated. So rather, as in the last question, we're thinking about too much iron rather than too little iron. Let's see the question associated with this stem. And the question is, what is the most likely diagnosis? I'll leave you for a moment to consider the answers to that question. The correct response here is hemochromatosis, but I'm going to briefly go through the other responses to see why we may be able to reject them. Wilson's disease is a disease of copper metabolism. There is a reduced carrier protein for copper in the blood, a reduced ceruloplasmin, and excess copper in tissues, which results in a form of cirrhosis. And in a 50-year-old, we would expect him to have neurological consequences of Wilson's disease, hence the name hepatolenticular degeneration, as it can affect the basal ganglia, and he could have presented with Parkinson's disease, for example. The second response is alcoholic cirrhosis. We know that he has a history of increased alcohol ingestion, but the clinical features of arthralgia and pigmentation do not really fit a diagnosis of cirrhosis secondary to alcohol here. Item C, acute viral hepatitis. We would expect much higher transaminases in a case of acute viral hepatitis, in the thousands very often. Although arthralgia can be found in acute viral infections, pigmentation would not be a usual feature. Excess iron ingestion. We know that iron is toxic to the body if present in excess. We know that it causes cirrhosis, it causes endocrine failure, it causes cardiomyopathy. However, you have to try very hard indeed to ingest enough iron to get significant problems from iron overload. It would have to be administered parenterally, and most usually it would be as a consequence of repeated transfusion in a patient with a congenital severe anemia. So the correct response here is hemochromatosis, and we're going to consider that disease in a little more detail. Hemochromatosis is an autosomal recessive iron loading disorder. You absorb too much iron from your diet. Although it's autosomal recessive, men are predominantly affected and women are very rarely affected because they are protected by monthly blood loss and by iron loss as a result of pregnancies. So unless a woman has had a premature menopause, it is unusual for them to suffer from hemochromatosis. The genetic defect is a mutation in the HFE genes that control iron absorption. And these may be detected fairly readily by a polymerase chain reaction on blood. Excess iron deposition occurs in the skin, giving rise to pigmentation, which is mostly melanin, by the way, and particularly prominent over the shins. Endocrine dysfunction, hence the name bronzed diabetes for this condition, and in the joints, giving arthralgia and arthritis, and in the heart, giving cardiomyopathy and cirrhosis. There is an increased risk of cancer of the liver, and the diagnosis may be made by screening for iron overload using transferrin saturation measurement, finding it to be over 55, and of course by looking for the HFE defect. The aim of treatment is to reduce the iron loading within the body, and that is most easily done by repeated venesection. These patients have a normal bone marrow. They will mobilize iron from the tissues into the red cells with repeated venesection. Initially, this will be done weekly, and then the frequency would be reduced, aiming to keep the hemoglobin over 11 and to reduce the ferritin to the low normal range, usually less than 50. We'll now consider the next question. A 16-year-old man with sickle cell anemia is admitted with breathlessness. He is febrile but has a clear chest with normal saturations on air. From his hospital records, he is found to have a usual hemoglobin of 9, but a blood count taken in the A&E department shows that he is more anemic than normal with a hemoglobin of 4.7. He has a hyperbilirubinemia, which is almost always found in sickle cell disease. They always have a tinge of jaundice, and he has an elevated platelet count, another common accompaniment. Which of the following investigations would be most useful to perform next? I'll let you consider that question for a moment. So, we're offered serum haptoglobin. If you hemolyze, releasing hemoglobin in the circulation, that hemoglobin is conserved within the body by binding to haptoglobin, the carrier molecule for free hemoglobin, so that it does not escape through the glomerulus and be lost in the urine. Therefore, reduced haptoglobin levels are a very sensitive marker of intravascular hemolysis. For most sickle patients, they would have reduced haptoglobin levels all the time. They always have a minor hemolytic process going on. So that's not a very useful investigation. What about item B, urinary hemosiderin? If hemoglobin escapes the clasp of haptoglobin, it disappears through the glomerulus and goes into the urine. Even then, the body tries to conserve it, and the tubular cells will ingest passing hemoglobin, and these tubular cells will be later desquamated, lost in the urine, where they may be detected as a urinary hemosiderin positive test. You take the urine, you spin down the deposit of cells, and you stain it for iron. This is a useful test to detect previous intravascular hemolysis, and it will usually be positive in patients with sickle cell disease. So this patient is more anemic than usual, and we wonder if he could have an aplastic crisis, and the most common cause of an aplastic crisis in sickle cell disease or any congenital hemolytic anemia would be parvovirus infection. So parvovirus serology could be useful in confirming this. Parvovirus B19 infects our red cell precursors in the bone marrow. In your eye, if we shut down red cell production for a few days, that doesn't matter. If our hemoglobin drops from 14 to 13.5, that doesn't matter. But if you have a severe congenital hemolytic anemia and you're dependent upon a massive outpouring of red cells every day, then that can result in a severe anemia. So parvovirus serology would be useful, but that test will take probably weeks in my experience to come back, and it may be one that we'll do, but not one of immediate use to us now in the A&E department. The correct response, as shown, is the reticulocyte count. Patients with sickle cell disease will always have an elevated reticulocyte count. If bone marrow red cell production shuts down, their reticulocyte count will be lower than usual for them. Their bilirubin level will also be lower than usual for them. If, on the other hand, we are dealing with a hyperhemolytic crisis, excess destruction of red blood cells, often associated with enlargement of liver and spleen, we expect a higher retic count than usual for them and a higher bilirubin than usual for them. Answer E, chest X-ray. This is unlikely to be of particular use, although this patient complains of breathlessness. We know that the pulse oximetry is normal and we know that the chest is clear to auscultation. Considering anemia in sickle cell disease in a little more detail, in general, anemia is well tolerated by patients with sickle cell disease. Hemoglobin S has a low oxygen affinity. It easily gives up oxygen to cells that require it. Consequently, transfusion is not a regular requirement in sickle cell disease. When a patient is admitted in sickle crisis, and that will commonly be microvascular occlusion, sickle pain crisis, it can actually be counterproductive to transfuse the patient because you will be increasing the hematocrit and the whole blood viscosity, thereby promoting slow flow, stagnation, hypoxia, and sickling. Generally, patients with sickle cell disease tolerate their anemia well. We have mentioned that a sudden increase in anemia to the life-threatening low levels we see here can be related to underproduction of the bone marrow, either due to parvovirus infection or occasionally due to an acute folic acid deficiency, and these patients, like all patients with hemolysis, should be on folic acid supplements, or can be due to increased destruction of red cells, particularly in children who may get rapidly enlarging spleen and liver, the so-called hyperhemolytic crises. In these situations, blood transfusion may be life-saving. We'll now consider the next question. So, a 54-year-old woman is referred to you with a possible diagnosis of essential thrombocythemia because her gynecologist had noted a high platelet count of over 500 on 3 occasions. Apart from 2 normal childbirths and a road traffic accident, there was no other significant previous medical history. Her hemoglobin and red cell indices are normal, with a platelet count of 580. The blood film report shows the presence of target cells, Hal-Jolly bodies, and occasional spherocytes. The question associated with this stem is shown in the next slide, and the question is, what is the next most appropriate step in your diagnostic workup? And I'll let you consider that for a moment. So, what are we offered? Bone marrow aspirate and biopsy. The myeloproliferative diseases, of which essential thrombocythemia is one, are in general associated with the overproduction of bone marrow and blood cells, which are morphologically speaking relatively normal. Consequently, with a mild thrombocytosis such as this, the bone marrow changes are not likely to be very marked. You will see increased megakaryocytes. That is because this lady is making more platelets. Occasionally you may see clustering of megakaryocytes or other morphological abnormalities, but it's not a particularly useful investigation. We know that inflammatory illness can cause a thrombocytosis, a raised platelet count, and so measurement of the CRP and ESR may be useful, but here we've got a very important clue in the stem, and that is the blood film appearances. Haematology bodies, target cells and occasional spherocytes are the classic appearances of the hyposplenic blood picture. Hyposplenic blood picture will also often include thrombocytosis, modest neutrophilia, or even lymphocytosis. So we have to remember, if you're hyposplenic, you may get a thrombocytosis, and we have clear evidence from the blood film that this lady is hyposplenic. So we could skip therefore to E and go back and ask this lady what happened at the time of her road traffic accident, what was the operation that was performed, has she got a scar that would be in keeping with a splenectomy after a ruptured spleen related to trauma. That seems the most likely explanation. All the other responses are appropriate in the investigation of a thrombocytosis. PCR for JAK2 mutation, which we'll be talking in a bit more detail in the next video presentation, that can be positive in 30% of patients with essential thrombocythemia, so that could be useful. Iron deficiency results in a thrombocytosis, even if not due to bleeding. So measurement of the ferritin level can be useful. But here the important clue is the hyposplenic blood film and the consequent presumption that her thrombocytosis is related to a previous splenectomy. If you have had your spleen removed, or if you are hyposplenic, then you will be susceptible to septicemia, sepsis with capsulate organisms. Consequently, there are a well-recognized list of precautions that you need to take in order to prevent such infection. Lifelong penicillin V, the sort of organisms that can kill you before you arrive at hospital, things like the pneumococcus, the meningococcus, Haemophilus, these are almost always universally penicillin sensitive in the UK, and therefore we would recommend lifelong penicillin V, a tablet night and morning kept with your toothpaste. Some patients still don't like doing this, and we recommend that they keep a course of penicillin at home to take at the first sign of fever or infection. Pneumococcal vaccine is now incorporated into paediatric immunization schedules, but most of us will not have received pneumococcal vaccine. If we are hyposplenic, we should receive it. Hib, I hope most of us will have Haemophilus influenza vaccine. If not, you need it. And similarly with meningitis immunization. There is a warning card shown on the screen that is available from the NHS for the patient to keep in their wallet, along with an explanatory pamphlet. And should they visit a malarial area, they will need meticulous anti-malarial prophylaxis. In the background of the display, you can see a blood film. The inclusions, the dark inclusions within the red cells, are the Haematology bodies. These are nuclear remnants that are usually removed from the spleen, the so-called pitting action of the spleen, which persist in the red cells if you are hyposplenic. We'll now consider the next question. Question 5. A 73-year-old woman presenting with symptoms and signs of biventricular failure. On examination, tachycardic, bilateral retinal hemorrhages on fundoscopy, but makes a clinical improvement following intravenous diuretic treatment. She has some investigations doing which show a borderline normal white cell count, a severe anemia, and this is a macrocytic anemia, borderline thrombocytopenia, normal electrolytes, borderline potassium, slightly elevated creatinine. The question associated with this stem is which of the following would be the most appropriate step in her management. The correct response in this case is red cell transfusion. This is a lady in biventricular failure. Inevitably, there will be a contribution to her heart failure from her severe anemia. Transfusion, and that will be cautious transfusion using packed red cells with 2 or 3 units only, is appropriate as a rapid way to correct her severe anemia. Other responses are correct, but not the most correct way of managing her. So it would be appropriate to give her intramuscular vitamin B12 for her macrocytic anemia. It would also be appropriate to give her oral folic acid. We can drop the appropriate vitamin when we get the results from the laboratory of serum B12 and folate assay. The serum protein electrophoresis is, of course, to look for myeloma, which can be a cause of macrocytic anemia. Bone marrow aspirate is not generally considered to be necessary in the diagnosis of macrocytic or megaloblastic anemia. We would usually reserve bone marrow examination for those cases who are not responding to treatment or there is genuine diagnostic difficulty after we have done the appropriate blood investigations. We will now consider some of the causes of a macrocytic anemia. Vitamin B12 and folic acid deficiency are, of course, the most common cause of macrocytic anemia, and it is likely that Our Lady falls into this group. Liver disease is associated with a macrocytosis, probably because of defective incorporation of lipids into the red cell envelope. Alcohol can give you macrocytosis in at least 3 ways. First of all, alcohol is a poison to your bone marrow and will result in defective red cell production. Secondly, alcohol taken long-term in excess can result in liver disease. And thirdly, alcoholics are not very good at 5 a day at eating fresh fruit and vegetables and may run short of folic acid. So alcohol can give you macrocytosis in at least 3 different ways. The MCV is usually quite a good guide as to whether your alcoholic has really stopped drinking or not, but bear in mind that red cells last for 3 months, so it takes a month or 2 for any changes to work through the system. Hypothyroidism is associated with macrocytosis, but just beware that you're not dealing with the associated autoimmune condition pernicious anemia. Young red cells are big red cells, so if you get hemolysis from any cause with a production of young red cells, an elevated reticulocyte count, polychromasia on the blood film, then you may get a macrocytosis. Finally, there is a little list of hematological diseases that are associated with macrocytic anemia but have their own special features. For example, a paraprotein in myeloma, a pancytopenia in aplastic anemia, and we should note, by the way, that this lady did have a borderline white cell count and a borderline platelet count. You can get modest neutropenia and thrombocytopenia in megaloblastic anemia, but not bad enough to give you thrombocytopenic bleeding or neutropenic infection. And then there is a group of disorders characterized by dysplastic changes in the blood, the myelodysplasias. Pernicious anemia, and this is likely to be a case of pernicious anemia, is an autoimmune attack against the intrinsic factor producing cells of the stomach. Intrinsic factor is responsible for grabbing B12 from ingested red meat, carting it off to the small intestine and delivering it to the terminal ileum. So intrinsic factor is the delivery lorry for vitamin B12. If you lack gastric parietal cells, you fail to secrete intrinsic factor, which fails to grab B12 from diet, so that it is not available to ingest in the terminal ileum. The parietal cells also produce gastric acid, and gastric acid is needed to release iron from protein so it can be absorbed. So patients with pernicious anemia have hypochlorhydria and may have borderline iron status. This is a reason for them getting iron deficiency superimposed upon macrocytic anemia when you've effectively treated them with vitamin B12. The vitamin B12, of course, has to be given parenterally. There is a macrocytic anemia with oval macrocytes in the blood and hypersegmented neutrophils, which you can see in the blood film displayed. In the bone marrow, we find megaloblastic change, and this series of morphological changes may be reflected in all rapidly dividing cells in the body. So you will, for example, find megaloblastic change in the lining of the gastrointestinal tract. So they will have sore tongues and mild diarrhea, and may even have a mild absorption. Probably the most worrying side effect of B12 deficiency is neurological damage. There are a variety of neurological syndromes that can be related to deficiency of B12. These include the classic subacute combined degeneration of the spinal cord, peripheral neuropathy. It's one of the things you measure in investigating cases of peripheral neuropathy, optic atrophy, which is subtly interwoven with tobacco amblyopia, and finally dementia. So B12 is one of those things you measure before you put down dementia to idiopathic dementia. In addition, there can be effect on other tissues such as the heart, so these patients may have a cardiomyopathy, which may be of relevance to this lady with her heart failure, and they may have impaired fertility. There is an association with other autoimmune diseases, particularly autoimmune hypothyroidism. If we wish to, we can investigate B12 absorption by means of the Schilling B12 absorption test. In this investigation, we give the patient a shot of ordinary intramuscular B12, filling up their carrier proteins, their liver stores, their bone marrow with B12. They don't need any more B12 for the moment. You then give them a radio-labeled capsule of vitamin B12 by mouth. If you can absorb it, you will absorb it, but now it's superfluous to requirements, and you will excrete the excess in the urine. You collect the urine for 24 hours, and there should be more than 10% of the swallowed radioactivity in that 24-hour urine collection, indicating the ability to absorb B12. If there isn't, you can't absorb B12, and that can either be due to lack of intrinsic factor, pernicious anemia, gastrectomy, severe gastritis, or it could be some defect of the terminal ileum, surgical resection, Crohn's disease. To distinguish these, what you can do is do the Part 2 Schilling test, which is exactly the same as the Part 1, but instead of giving plain radio-labeled B12, you give a combination of radio-labeled B12 with intrinsic factor to see if you can correct malabsorption found in the Part 1 Schilling test. There is also a Part 3 Schilling test, rarely performed, where you give broad-spectrum antibiotics just in case this is a case of competitive consumption of B12, where bacteria in the normally sterile small bowel proliferate and consume B12 before it reaches the terminal ileum. Bacteria of three sorts: those that make B12, those that consume B12, and those that don't give a hoot about B12. And if you get blind loops or diverticuli of the small intestine, they can become colonized by bacteria that gobble up B12, hijacking it from intrinsic factor before it reaches the terminal ileum. So this lady most likely has pernicious anemia. She will receive quarterly intramuscular B12 for life. If she stops the vitamin B12, That will result in a gradual consumption of her stores of B12 in the liver, and the symptoms of her pernicious anemia will recur, but normally there will be a 2 to 3 year delay depending upon how big the stores of B12 in her liver are. We'll now consider the next question. Question 6. You're asked to review a 63-year-old woman who is anemic with an elevated reticulocyte count, an elevated bilirubin, and fragmented red cells on her blood film. Which of the following diagnoses causes a microangiopathic hemolytic blood picture? So we have a lady with an elevated reticulocyte count implying destruction of red cells or removal of red cells. We have fragmented red cells on her blood film, implying destruction by fibrin strands. Microangiopathic, small angio blood vessel pathic disease of. So if you get disease of small blood vessels with laying down of fibrin strands, that can damage passing red blood cells. Some of these can reseal themselves and go on as half red cells or fragmented red cells, which can be seen on the blood film. So we're offered various options for a microangiopathic hemolytic blood picture. So the first option is cold agglutinin disease. This is due to the presence of a complete agglutinating antibody in the patient's serum, which in the cold, particularly the cold peripheries, or when blood is removed from the body and cools to room temperature, causes clumping of red cells, causes the formation of cold agglutinates. Most often, the laboratory will alert you to the presence of cold agglutinins in your patient when they make a blood film and they see clumps of red cells which have been agglutinated by an IgM cold-acting antibody, usually directed against a core antigen on everybody's red cells, that is the I antigen. Fragmented red cells are not a usual feature of cold agglutinins. The correct response is immune vasculitis, an immunological attack against small blood vessels, resulting in them becoming inflamed. Wherever you get small blood vessels inflamed, they may damage passing red blood cells. So, for example, in glomerulonephritis, a third of your cardiac output goes through the kidneys. So if you get inflammation of the glomeruli, you may see fragmented cells on the blood film. March hemoglobinuria is an unusual condition associated with destruction of red cells in the soles of the feet. It is a little uncertain whether it is a defect within the red cell envelope of these patients or whether it's the way in which they walk. It was originally described in troops doing forced marches, physical trauma to the red cells in the soles of the feet. These red cells are generally completely destroyed, and though you may see all the features of hemolysis, such as anemia, reticulocytosis, you do not usually see fragmented red cells. The red cells are destroyed completely. Idiopathic thrombocytopenic purpura. This is a disease of platelets resulting in immunologically mediated premature destruction of platelets. It's got nothing at all to do with red cells. Perhaps the evil tricks department is trying to confuse you with thrombotic thrombocytopenic purpura, about which we will talk in another presentation. And finally, paroxysmal cold hemoglobinuria. This is a rare hemolytic condition associated with a IgG-fixing cold-acting antibody against red cells. It used to be seen in syphilitic old men. Now it's most commonly seen in children with intercurrent viral infection. And what happens is, in the cold periphery, an IgG antibody sticks on your red cells. Then in the warm central circulation, there is a little explosion of enzymes, complement fixation, which blows holes in the red cells, releasing the hemoglobin, resulting in hemoglobinuria. This is not associated with fragmented red cells. We will now think of some of the causes of a microangiopathic blood picture. In the blood film on the screen, you will see that there are fragmented red cells. Those are the very irregularly shaped red cells. There are also helmet cells, which have been chopped in half and resealed, like the helmets that our troops wear. And you can also see the very small, darkly staining red cells, which are spherocytes. Spherocytes may be found in the blood in any cause of hemolysis. Of course, the classic causes are hereditary spherocytosis and warm autoimmune hemolytic anemia. But you will also find them in small numbers in a microangiopathic blood picture. So the causes are disseminated intravascular coagulation, which we'll consider in more detail when we talk about coagulation in another presentation. It is of note that this blood film shows no platelets at all. This patient is thrombocytopenic, so DIC would be a possible diagnosis here. Vasculitis, we've already mentioned immune vasculitis, and we've mentioned glomerulonephritis. And we will deal in more detail with the disease thrombocytopenic purpura in the coagulation lecture. Now we'll consider the next question. A 24-year-old Kenyan student presents to A&E with fever and rigors. On examination, he has an enlarged spleen. In the past, he is known to have suffered from several bouts of malaria and takes anti-malaria prophylaxis intermittently. The laboratory report an infection with Plasmodium falciparum. An anti-malarial treatment is started. 2 days later, however, he is acutely unwell with oliguria, a creatinine elevated to 450, a severe anemia with a hemoglobin of 4, and an elevated reticulocyte count of 25%. Let's see the question associated with this stem. What is the most likely diagnosis? The descriptive term blackwater fever most appropriately fits the clinical situation. This is hyperhemolysis associated with severe falciparum malaria. The exact cause is a little bit obscure in that it's thought that immunological mechanisms may play a part. It's thought that low-dose quinine therapy may be somehow involved in that. But in practical terms, the patient is severely ill with their falciparum malaria, and remember, about 20% of such patients will die. They have black water, that is heavy hemoglobinuria, severe fever with rigors, and a falciparum infection in the blood. So that it most fits the clinical stem. Let's think about the other possibilities. What about a drug-induced hemolysis? Quinine is associated with an immune thrombocytopenia. Fairly commonly, in my experience, patients who are given quinine for nocturnal cramps may present with an acute immune thrombocytopenia which is related to quinine therapy. However, drug-induced hemolysis related to antimalarial therapy is extremely rare. Antimalarial therapy may, however, precipitate hemolysis in patients known to have G6PD deficiency. But 2 days into treatment seems a little unlikely. Sickle cell disease, we're not told anything about his history, but you would have thought that if he has sickle cell disease, that would have been either previously found or found on this round of laboratory investigations. Tropical splenomegaly is an interesting clinical scenario. Usually in my experience found in patients who spent many years in the tropics, usually who've been successful traders in the tropics, who have had perhaps too many pink gins on the veranda and perhaps too many poorly treated malarial infections, resulting in chronic enlargement of their spleen. These patients with tropical splenomegaly may be hypersplenic, may actually present with a pancytopenia. Let's consider the diagnosis of blackwater fever in a little more detail. This is associated with a heavy falciparum infection of the red cells. On the screen you can see these malarial parasites, characteristic of falciparum, that is, there are often more than one parasite in an infected cell. They have the characteristic signet ring appearance with the red chromatin dot. Sometimes they have a double chromatin dot, a double ruby in the signet ring, and often they are attached to the outside of the red cell. It's usual to count the percentage of parasitized red cells in falciparum malaria with very high parasite infection, very high percentage of involved red cells. Exchange transfusion may be used as treatment. We'll now consider the next question and stem. Question 8. A 62-year-old man goes to the clinic with fatigue, and his blood count shows a low white cell count, a low hemoglobin with modest macrocytosis, and a low platelet count. He therefore has a pancytopenia. In keeping with this finding of pancytopenia, he has a bone marrow aspirate and trophine biopsy, which I'll show you in a moment. This is hypocellular, but with persistence of lymphocytes, reticulum cells, that's the phagocytic dustbin lorry of the bone marrow, and some plasma cells. What is the most appropriate treatment? In order to allocate the appropriate treatment, we have to make a diagnosis, and I think we have sufficient information with the report of a pancytopenia and a hypoplastic bone marrow to make a diagnosis of aplastic anemia. So we can rewrite the question as, what is the most appropriate treatment for his aplastic anemia? All the options provided would be potentially useful in aplastic anemia. I'll let you consider which is most appropriate. So, pegylated GCSF, granulocyte colony stimulating factor, can stimulate committed myeloid precursors within the bone marrow and can stimulate what residual neutrophils he has in the blood to work harder. GCSF can be a useful treatment in aplastic anemia, but it does nothing for the underlying disease. It does not restore bone marrow function. It can stop your patients with aplastic anemia dying of infection before you give them an appropriate treatment for their aplasia. Pegylated GCSF is a growth factor which has been coupled to polyethylene glycol, resulting in a prolonged half-life. You will only need to give PEG GCSF once a week, whereas conventional GCSF needs to be given usually on a daily basis. So useful, but not the answer. A careful history will have been taken from this patient, particularly as regards drugs or occupational exposure to toxins that might affect bone marrow function. We assume that we found no drugs that would cause aplastic anemia, that he does not have a history of recent hepatitis from which he's recovered, and that he hasn't been exposed to radiation. Assuming, therefore, this is what we would call idiopathic aplastic anemia, then the most appropriate treatment in a gentleman in his 60s would be immunosuppression with anti-thymocyte globulin. This is an antibody raised in animals, horses or rabbits, by injecting them with human T cells. The animal makes an antibody against the T cells, and we can infuse this into our patient, removing the population of suppressor T cells that we think are attacking his bone marrow stem cells. Most cases of idiopathic aplastic anemia are an autoimmune attack against your own bone marrow stem cells. The mainstay of immunosuppression will be treatment with anti-lymphocyte or anti-thymocyte globulin. What about bone marrow transplantation? It's an attractive option to take his residual bad bone marrow away and give him some fresh bone marrow. The problem is that even with a reduced intensity conditioning regime, which we can give him because he doesn't have a malignant bone marrow disease and his bone marrow is already half empty, even with a conditioning regime of reduced intensity, that is a risky procedure. At least 5% of patients who have a bone marrow allograft will die as a result of the procedure. We would aim to avoid that risk, which is higher the older you are. The young do best. So if he was less than 50, and particularly if he had an HLA-matched sibling donor available, then bone marrow transplantation would be his best option for the treatment of severe aplastic anemia. But over the age of 60, we would generally use immunosuppressive treatment as our first treatment designed to affect the underlying disease. Corticosteroids are used as part of the triple immunosuppressive treatment of ATG, cyclosporin and methylprednisolone. The reason we give the corticosteroids, the methylprednisolone, is not for its immunosuppressive action against the T lymphocytes. It's because we're giving an animal immunoglobulin over several days, and there is a risk of a reaction against that immunoglobulin, giving a syndrome of arthralgia, fever, lymphadenopathy, which you will recognize as serum sickness. So to prevent serum sickness, we would usually give corticosteroids with our ALG and cyclosporin. Oxymethylone is an androgenic hormone. These are the tablets the shady man behind the gym will try and sell you. Not only do they improve muscle bulk, but they can also boost your blood count. However, they only have a weak action on the blood count, and we would usually reserve oxymethylone for those situations where there is not another alternative to treat the aplastic anemia, such as in this case, anti-thymocyte globulin. So this is a picture of the bone marrow trephine from our patient with aplastic anemia, showing preservation of the bony spicules, the pink bits with their Haversian canals, but in between there are empty fat cells. This is yellow, inactive bone marrow. Bone marrow cellularity is best assessed on a bone marrow trephine, where a core of marrow has been removed from the patient's iliac crest, decalcified and sectioned histologically. We'll now think about aplastic anemia and its treatment. First of all, you have to remove the cause if known. As mentioned already, careful drug history, careful history of occupational exposure to toxins, history of virus exposure, particularly the hepatitis viruses. Supportive treatment will be necessary for the majority of patients. That involves red cell transfusion for correction of anemia, platelet transfusion for symptomatic thrombocytopenia, particularly with a platelet count less than 10, antibiotic treatment for intercurrent infection associated with neutropenia, and GCSF treatment to help the neutrophils that are there work better. Immunosuppressive treatment, as already mentioned, with ALG, cyclosporin and steroids, and stem cell transplantation for the younger, fitter patient, particularly if they have a matched sibling donor. But remember, only 1 in 4 of our brothers or sisters will be a match for us. That concludes this video presentation on anemias and cytopenias. I hope that's been useful to you, and I hope that you will take the opportunity to see the other 2 haematology video presentations in this series. Thank you.